Morning, everybody. This is our June staff meeting. It already is June. I can't believe that. So we're going to start out this morning. This is going to be a little bit different kind of meeting. This is very focused on infection control and the basics that we need to be using every day. But we're going to start out first with Kyle doing a little safety story for us. Go, Kyle.
Okay. Alright, so we had a little fall in the OR a little while back. It doesn't happen very often, but it was handled pretty well. So I just want to review that with you guys. I won't focus so much on how the fall happened. It happened, it's unfortunate. There was appropriate people, it was safely transferred. There was a bed rail that failed, or something happened with the bed rail, and the patient fell between the two beds after the transfer was complete and slowly fell to the floor. Once the patient was on the floor, people were quick to try to rectify that immediately, but that was stopped appropriately because we don't need more people injured. So that was stopped, and we did work towards acquiring the appropriate safety equipment. We do have several options, actually. So we did have a movable Hoyer lift, but we elected to hold off until we could get the hover jack, sorry. It's closely associated with the hover mat. So we got the hover jack, and one of the things that is so nice about the hover jack is once you slide it underneath the patient, you can maintain their body alignment instead of folding them in half like the Hoyer lift does. In case there's any further injuries, it's probably the safest way to get the patient off the floor and over back onto the gurney. So a couple other points that were really nice to hear is there was conversation going on. It is a high stress moment. People were quick to remind that the patient was still indeed awake and to watch what we were saying. They were a larger patient, and so that was really nice to see and hear. Once we got the patient off the floor, did a quick head to toe, anesthesia was there, checked them out. And we also got a inpatient hospitalist consult. They wound up staying the night just to make sure everything was okay. As a conclusion of this safety story, we actually do have one of the issues that we had was it took too long to get a covered jack. We don't actually have one in our department. So people were very good. We got the patient a pillow to put under their head, warm blankets to maintain their body temperature and to keep them as comfortable as possible in a very uncomfortable situation. But we do now have a hover jack on order. It should be in shortly, and I've been in contact with the rep to do a nice little in-service for staff so that we can properly use the equipment. It's very easy, very self-explanatory. I haven't been trained on it in like 5 years, but it came back to me very quickly. So you should be seeing that shortly in the next couple weeks, and it'll be a fun in-service because it is a fun in-service. All right, thank you very much.
So we're going to have those stocked in our department now, or?
The hover jack? I'll let you know where we decide to have it live.
Also our fire evacuation, right? Like if we have to take people down the stairs or something?
Yeah, it is that fun thing. If we have to evacuate patients from like the 10th floor, that's how we slide them down the stairs.
Anyway, more coming, and we're only getting one, so we'll only be on one floor.
Yes.
Yeah. All right, I'd like to welcome our new employees. Edmund, stand up, Edmund. Where are you, honey? There's Edmund. Glad you're here. Caitlin Budson is a new RN. She's not here today. She's per diem. So if you see her, make her welcome. Sarita Miller is a new CNA transfer. I don't think, is Sarita here? Okay. And then Jacqueline Lee is an anesthesia tech who is a transfer from Swedish. Tammy, do you know how to say Tammy's last name?
You?
You? Tammy's not here this morning, she's taking a final, but she's a new employee for a new CNA. And then Heather Monte, a new surgical tech. Stand up, Heather. Yeah, we're glad you're here. Welcome, welcome. And again, make everybody feel welcome. There is an attestation. I apologize for not having enough. I had like 40. I don't know if y'all are like collecting these. But anyway, if you did not get an attestation, let me know and I'll be sure to get you one. This is something that is kind of been, we need to read these things. We need to make sure that you know that these are the values-based service standards and behaviors. Everybody gets this information when they're a new employee, and there have been some instances of maybe we're not treating each other very professionally. So that has come up, and as a result of that, we're asking that you review these standards and treat each other in a professional manner, and you sign an attestation for that. This attestation will go in your file. Any questions on that? These are things your mom should have taught you when you were growing up. Okay, Robbie, got a question?
I got a question on clarification on the recycling, as far as, the plastic and all the cardboard. Because, we still have bins for it to be collected, but then we were told that it just goes in the trash, so.
I don't know. I think we'll have to talk about that offline. I don't know the answer to that. I thought Cheryl was going to get some heated attestation questions. You totally threw me asking for recycling. But Robin, good question, and we'll figure it out and get back to you. Yeah. I don't think we do too great on recycling here, but yeah, there's issues. So any other questions? We're all good? If you have questions, you know who to talk to. You can talk to your supervisors or your manager about this. All right, we're going to just do a little update on surgical site infections. I know everyone's heard this, but this is your formal report on the infections, what it means to us, things that we need to do to make it to where our patients are safer. So there's been an increase in orthopedic total joint infections, with 7 infections occurring within the first quarter of 2018. So that's crazy high. So we're trying really hard to really look at the basics of how we practice every day and to brush up on the basics and make sure that our patients are safe and they don't leave with anything like an infection.
Sorry.
That was perfect time.
Good morning, everybody. Sorry, I was just at the admissions meeting talking about nose to toes protocol. So surgical site infections, everybody's favorite topic. It's been a hot topic lately, as you've heard. So this is just a quick dry slide on surgical site infections so that you can understand how they're actually reported. We don't report surgical site infections in rates anymore, so I can't tell you that we have a 25% rate. They're basically reported to the NHSN, which is a branch of the CDC. They only report 39 categories, so we don't report every surgical site infection that we have, but we do report 39 categories. The data is used to calculate this SSI, or standard, the SSI that we have are used to calculate the standardized infection ratio is how we do it now, or the SIR. And why that matters is because we need to know the number of observed infections, which is the number of infections that we have, divided by the number of infections that we're expected to have. And you don't know the number of infections that you're expected to have until you report your data, because it's a national benchmark that you're basically graded against. So the goal is to have a SIR less than 1. If you have 1, then you basically have exactly the number of infections that you are expected to have. If you are less than 1, you're better than expected. If you're more than 1, you're not as good as you're expected to be, essentially. And the goal, obviously, ideally would be to be 0, but you want to be at a minimum less than 1. So here we are. Here's the last 3 years, courtesy of Sarah, who just walked in. Sarah Wilkerson, for you guys who haven't met her, is one of our infection prevention nurses. She provided me with this slide, which is great. And the reason why I had to go over the SIR is because, as you can see over in that column, that's how your surgical site infections are reported. So back in 2015, we had a SIR. We're still under 1, but we're at 0.89. This is all of our surgical site infections together, not just total joints. 2016 got a little bit better, we're 0.84. 2017, we did some really good work, because we're down to 0.446. But we're not zero, okay? We're always going for zero. So here's what Becky was just talking about. In 2017, we had a total of 7 infections. So for the last 3 years, what we were expected to have was actually a total of 9. And the way that broke out was 6 hips and 3 knees. So in 2017, we ended up having 4 knees and 3 hips infections. And this is the way they were dispersed over 2017. Okay? So, not too bad. And then what happened? This is where the red flag came up. So this year, February, March, and April, all of a sudden, we have 7 total joint infections on the book. And that raised an alarm, because now all of a sudden the big question is, what happened? What changed? We had no supply changes, no practice changes, nothing was obvious. There's no pattern in the rooms, crews, surgeons, there was absolutely nothing obvious about this. So now what? Here's the thing with total joints. Total joints have a longer surveillance period because infections in total joints are fairly devastating. They tend to be rare, but they're devastating. So the surveillance period is 90 days, okay? Inside 90 days, it's considered a healthcare acquired infection, which means no matter what the infection reason is, if it happens within 90 days, it's attributed to their healthcare experience. So if it's outside the 90 days, it's another source. All of our infections in 2018 were acquired within 15 to 39 days. That means it happened at some point in time in their healthcare experience. And the OR is always on alert for these healthcare acquired infections, because what we do, everything that we do, is to prevent infection. So, what does it mean for us? Higher daily costs for a patient when they're infected, increased length of stay, more readmissions, so a patient comes back when they get infected, and these are patients that are coming back that we don't expect to have back, which means we now have patients in the hospital that we don't expect to have, and we have other patients that are sick, and then we run out of bed space. As you know, you keep hearing the red zone, and bugs are lasting longer, so these viruses stay around. What do SSIs cost? This is one example from one institution in 2014. So the mean SSI was $11,000, almost $12,000 for one surgical site infection. The range for a superficial is skin or subacute, is $7,000. When you get down to deep or organ space, you're looking at $25,000. And this is, again, one institution, one infection. And this is from the Veterans Affairs. And this was in 2014 dollars. So, what does it mean for our patients when they get a total joint infection? This is the interactive phase. What does it mean?
Readmission to the hospital.
Okay?
IV antibiotics,
For how long?
long time, 2 weeks, I think at least.
Probably at least 6 weeks of antibiotics, and if you're getting 6 weeks of antibiotics, you're probably getting a PICC line. What else does it mean? Are you going to keep that joint implant in?
It depends, sometimes they can, sometimes they can't.
Probably not most of the time, so you're probably coming back for another surgery to get your joint implant that you just had in out, and you're probably going to get an antibiotic spacer, right? Then you're going to get a PICC, you're probably going to get 6 weeks of antibiotics, and then what? You're going to get cultured, because you have to be bug-free first. So if you get bug-free, and hopefully you will, then you can come back and you get a revision, and if everything goes amazingly well, and you don't get infected again, and you stay away from the dentist's office, you'll probably do okay. Does that always happen?
No.
No. So patients don't necessarily always do well. That's probably the best course that they can do. Some patients may not fully recover from that. Patients get septic. You can die from sepsis. And I will tell you that I just did a surgical site infection review case, and it always makes me stop for a minute when I get an alert that says, this patient is deceased. Do you want to continue? And I'm like, well, yes, I do. And then I go in and I find out the patient is my age, and I'm like, huh. So it makes me stop for a moment. I don't know what happened because I'm just reviewing the actual operative phase, but it makes you think about it. So sepsis can kill, infection can kill, essentially. So the other thing that can happen with total joints is you may not be able to redo that joint. They can get osteomyelitis, which is a horrific infection in the bone, which you may not be able to resolve. Sometimes you have to fuse joints, and sometimes you have to amputate. So that's sort of your worst case scenarios. So just think about that. So this can have a financial repercussion for us. The patient story, on the other hand, is the bigger story, and it can be a fairly decent progression where we can do the revision, the antibiotic story, and we can make it better, or we can have the worst case scenario for the patient. So there's a lot that happens with that patient. Our goal, SSI elimination, not just prevention.
So you might ask, what are we doing about SSIs? Well, guess what? We're going back to basics. So this morning we're going to review some of the things that are most basic to our practice that you ought to be thinking about every single day. What do you think the very first thing is going to be? Come on, people, hand washing. There it is, hand hygiene. We stink at this, okay? We're supposed to be like being audited frequently. That means if you're touching a patient or if you do something and you take your gloves off, guess what? You're supposed to do some hand hygiene. So again, I want you to think about that. You actually, as you said, hand washing is the most effective method of preventing patient infections. And you have to do this every day. And this is earth-shattering here. You're actually supposed to wash your hands before you go into the OR every day. So, guess what? I don't mean just wash your hands. I mean wash your hands with soap and water. And under running water, use that little nail pick that's on the top on the counter and clean your fingernails under running water. Then go ahead and wash your hands with soap and water. Dry your hands with a paper towel. And if you're, after that, if you're using gloves and you take your gloves off, you need to perform some kind of hand hygiene like Purell. Questions on that? Esther?
I have a question about having gone to the bathroom or gone to eat and then come back and just doing a surgery, just doing
Like an alcohol rub or something?
Yeah.
That's hand hygiene.
I know, I'm just asking.
Okay.
Because, we go, oh, first piece of the day, we're gonna do we're gonna scrub and we're gonna pull all that crap out of our nails, but then I'm gonna go and eat a burger. And then I'm gonna come back and I'm just gonna gel. I'm just, maybe that's
Well,
fine.
we're going to go over, thank you for bringing that up, Esther, but we're going to go over the basic method of doing alcohol rub. And part of that is you wash your hands and again, clean your fingernails. Okay, Rebecca, you got a question?
Have we thought about also with the reps teaching them proper hand washing before they come into the OR?
Well-
They touch the implant boxes and lay them on top of the case cards, they touch their iPads, they touch everything, they go sit in the lounge.
I hear what you're saying, but we have to go step one, and that's us. I will tell you that this presentation is being shared with the surgeons because some of our surgeons might need an update on technique. But anyway, thank you for your questions. So hand hygiene, guess what? Basic. Before you touch a patient, before you do a clean or aseptic procedure, after you're exposed to any body fluid, after touching a patient, and after touching patient's surroundings. So again, I know the OR, what I hate to see most of all is somebody putting a pair of gloves on and just wearing those gloves for hours. If you're circulating, you should not be doing that. You should do whatever, put your gloves on, do whatever you need to do, take your gloves off, perform hand hygiene, and then if you have to do something else, then you put another pair of exam gloves on and go from there. Is this a general consensus? Is this how y'all think about doing it? I see some nodding. Thank you. All right, guess what? This is basics. We're going to talk about OR attire. You all know this, so brace yourself. This is just strictly a review for everybody. Okay, you got to have these fancy bouffant hair covers. We don't have doctor paper hats anymore. I see some. But if you wear a cloth hat, you have to wear a paper hat over it. Beard covers, we're really cracking down on beard covers. Please, if you have a beard, and I think everybody knows this, but this is review time. If you have a beard, you have to wear a beard cover. Containing or not wearing jewelry. Your ID badge should be visible. We really frown on lanyards, so if you have a lanyard, you need to get something that's like the little stretchy thing that it won't, when you're prepping or whatever, that your lanyard won't be contaminating your prep field. Remove your mask after case, and I know that this is usually not us who are the people who walk around with their masks on, but if somebody comes up to you and says, hey, you might want to take your mask off, don't get mad. We should all be able to do this to doctors, anesthesia personnel, because it's part of being a professional and adhering to the policy. All right, so if you're wearing shoe covers, and that's fine if you want to wear them, you just have to take them off before you go down to the cafeteria or leave the department. Grosses people out of the cafeteria. Use PPE, personal protective equipment, such as eye protection per policy. Questions on that? You know you're supposed to wear your jacket, you're supposed to have it snapped up, you're even supposed to prep with your jacket on. Does anybody know why? My fellows, why do we have to wear jackets? Skin flaking. Splains. We don't want to drop a bunch of splains on our patient. Everybody should remember that word. It's good. All right, traffic patterns. Again, super basic. That's why we dress funny. You know, a non-restricted area or unrestricted area is how we come to work every morning in our street clothes. Doesn't matter. It's all cool. But then when you dress to go in a semi-restricted area, you have to do everything we said except you add a bouffant hat. Okay, so if you cross the red line, you have to have your scrubs, your jacket snapped up, your beard cover if you need one, and your hat. Now restricted, everybody knows what restricted is. That's the OR when your supplies are open, your sterile field is open. That's when you add your mask, okay? Any questions about that? Again, I think we're trying really hard to not use the main OR door. Sorry, get some reverb. Once the patient's in the room, we all ought to enter and exit through the corridor. I think we've done some really good work on that. I know for the UPC it was a standard of the month, and I think we do well on that. I think, again, the people who might not be doing that are people who are vendors or anesthesia, and we're working on that. And we have the right to question entry into the OR by non-mandatory staff. And again, I think the RNs know this. If you have a bunch of people in there that don't need to be in there, you can ask that they leave until the appropriate time. Questions? Yes, Miley.
Should we have using corridor once the sterile field is open, or the patient in the room? Over there, it just says the patient in the room.
I'm going to lose that, and you leave that to your critical thinking skills, but you should be thinking about traffic patterns once your patient's in the OR. Sterile conscience. Let's talk a little bit about sterile conscience. Does anybody know what that is? This is the interactive part too. Anybody know what sterile conscience is? My fellows, come on, what is it? Okay, Pam, what is it?
It's if you think it's unsterile, it is. It doesn't matter whether it is or isn't.
Correct.
If you think it is, it is. And if they argue with you, you touch them, and then it is unsterile.
Well, that is the old-fashioned way. That is the old-fashioned way, and I have used that too. Yeah, it's not sterile now it's contaminated for sure. All right, but what it is really is, it is observing yourself, and you're keeping yourself to a standard that if no one is in the room and you accidentally contaminate something, who's to know? You know, it's going to be a lot of trouble for you to open new supplies or whatever. Well, sterile conscience is having enough on the ball to know the impact of one little error like that. Even if no one knows, you know. So that means that you would take the appropriate measures to make sure that you had corrected that contamination. So it's constant surveillance of the sterile field. See something, say something. Observe breaks in technique must be reported and corrected. And you shouldn't be fearful of reprimand. In the OR, if anybody calls it as unsterile, it's contaminated. There's no argument. It's just, okay, let's get it fixed. Questions on that? I think pretty much everybody is over this. All right, sterile instruments and supplies. You know, we can't work without sterile instruments. That's part of our whole deal. So This requires vigilance when you're handling your sterile items. You obviously should check the package integrity before you open anything. You want to check your indicators and integrators to make sure that that set or pack or whatever is sterile. You want to deliver it carefully to the field. I know that some of the way things are wrapped, it's tricky to open them without contaminating, but just do the best you can, and if you can't do it, go ahead and try again with something else. Any foreign object in the sterile set's deemed contaminated. I know that we're currently doing that. If you see something foreign in your instrument set, there's really, I know right now we're calling supervisors, but my point is, you know it's not sterile if something's in the pan. So do whatever you need to do to make that right. And again, if there's any doubt about sterility, don't use. And again, what's been announced lately at the Daily Huddle is the blue wrappers. They are a double wrap, and if one of those layers of blue is torn or not intact, then the entire thing is considered contaminated. Any questions on that? Yes, Robin?
I got a question. When things fall on the floor, I mean, it's old school, it's like what's on the floor, it's contaminated, and I know that stems back from a sacred cow when we use cloth wrappers.
Right. When things fall on the floor, are they considered contaminated? What do y'all think?
Are you talking about an item that's still wrapped?
Yes.
Just clarify.
Clarification is good. What are your thoughts on that? What about if it's a peel pack? What would you do if you dropped a peel pack? Would you use it? Would you check the integrity of the package? Okay, that's what I would do. I do know that that is an old school thing, and it was when everything was wrapped. And the thought that when it hits the ground, the compression of the air might suck up something unsterile. So my answer to that is the integrity of the package is what drives the sterility. It's event related. So again, use your critical thinking skills for that.
The floor is always considered contaminated. So if it hits the floor, it's considered
You guys just said
contaminated.
two different things. Yeah.
So, like if linen hits the floor in the room, it's considered contaminated. So we'll do a standard verification on that. It is an old school practice, but I don't think it's actually old school. Pretty sure it's still the standard, but we'll do a verification on that.
We'll get back with you on that, because obviously I'm hearing two things too.
Do you want me to speak up on that one?
Yeah, sure.
So the peel pack in it has two wraps,
Mhm.
and the inner wrap is still okay, you could remove the outer wrap and use the inner, after you use proper use, you can use the wrap. The plastic can be wiped down, and you can do that, but generally speaking, if it hits the ground, it is.
It's done.
Yeah.
Okay, thank you, Sarah.
And you will get cited if you don't come to first or something else.
We don't want to get cited by joint commission, so if you drop it on the ground, it's done.
So you would.
Okay. All right, sterility is event related. I touched on that just a moment ago. There's a lot of questions going around right now about bringing sterile supplies into your room, and if you don't use them, what do you do after that? So I will tell you that the first and foremost thing is, do you really need to bring all those items in your room? Okay, if you're bringing them in your room just in case, you might want to rethink that. If you have to have them, you have to use your critical thinking skills to make sure that they're not in an area that is dangerous to them being contaminated. So you wouldn't want your sterile packs up close to the sterile field where they might get splashed or whatever. You don't want that. To me, if I had a lot of instruments, again, there's a lot of talk about the case carts, what you can and cannot put on top, inside, whatever. I'm telling you that if it were me, I would put my instruments on a different table and use my case cart to put my dirty things in. So again, hold your question, please, let me finish. So if a package or rigid container had not been compromised while in the OR, it remains sterile. So you can return it to the shelf after the case if it's not compromised. Miley, you have a question?
Sometimes the Pixis peel packs or the Y-Rack peel packs have dust on the outside of them, or even And inside, like before you peel pack, there's like a little piece of debris, so sometimes I have to dust them off before we open it to the field, otherwise the debris from the outside of the package ends up in.
Well, I would say that, first of all, we should not be having dust in our peel packs. Maybe we need to have someone take a look at that periodically to where that doesn't happen. But yeah, that's good that you check, but I would question if something has been on the shelf long enough there to be dust or debris in the part where you pull it apart, I would question using that at all.
I've seen them, I'm just mentioning it
Right.
since we're discussing this.
Yeah, well, I would think that would not be great. Holly, question?
So, at least 2 times when we have a TB patient in the room, I get questioned by staff about all the packaged goods that have been in the room, what to do with them, whether they put those ones back on the shelf or not. So you're saying yes?
Well, now you're opening up a whole different thing when we're talking about isolation.
Well, I've had that question twice, so I
Right.
can get an answer from the office because they don't know what to do.
You should not bring a lot of extraneous things in your room if you know you're doing a TB case.
Definitely.
But see, there are times when we don't know, and I think that should be looked at. But
So, more to come.
more to come. I don't have the pat answer on that. That's yet another, staff meeting topic is
So for
isolation.
now, should I tell them to get rid of the supplies?
Yes.
Or- Yeah.
Yes, there's your answer.
Bring in only what you need,
Bring in what you need.
and if you have it, discard it.
If you have it, you brought it in the room, and you find out the patient has TB, it goes back downstairs to be decontaminated.
Ideally, we know ahead of time.
Like sutures.
Yeah, everything.
You can put it in a plastic bag or something to protect it.
Then you're okay.
Okay, Sarah's saying if we put it in a plastic bag and it's protected, we wouldn't have to discard it.
Yeah, and I would say for any case, not just any cases, so anything that goes in the room needs to be protected from contamination, because there's so much aerosolization that happens during the case when you're using pottery and irrigation. So any way that you can protect those supplies, but ultimately not bringing it in.
Right.
You know, in-
So Sarah's saying protect your sterile supplies in your OR. Okay, thanks, Sarah. Any more questions? It's touchy topic. Okay. Obviously, everybody knows this, it's our policy, we double glove. If you're scrubbing and you're not double gloving, you're not abiding by our policy. So again, remember this little presentation is for other people than us who don't double glove, who aren't, in our staff. So again, it's an indicator glove system. It's made to where if there's any break in your outer glove, it will show immediately because you have an indicator glove. And again, I think nationwide, this really is the gold standard, and I'm proud that we go by this. I just wish everyone that scrubbed would go by this. Esther, question?
Surgeons?
Surgeons.
I'm just asking, are they going to be mandated to do this? Because they don't.
Esther, I'm just telling you what we're doing.
Okay.
I cannot mandate what a surgeon does. This is going to be presented to them because we're covering everything that it could impact their patient getting infection. But thank you.
You're welcome.
All right, there's a revised plan on cleaning the ORs now, and I'm sure you've seen it. We're trying really hard to look at basically how we turn a room over. In the past, it was just a flurry of a bunch of people coming in a room and doing some stuff, and maybe everybody wasn't sure what the other person was doing, so we've tried to make it to where it made sense. We've broken the OR down into 3 zones. The A zone is anesthesia, the B zone is around the OR bed, and the C zone is the circumference of the room. So that's what we're trying to do. So when you use this method, and everybody's been trained to do it, you have to call out your zone. So when the turnover team comes in, somebody's going to say, I have the A zone, I've got the B zone, I've got the C zone. Okay? So you have to actually communicate with your team. And again, the anesthesia techs, the CNAs, SSAs, RNs, scrub techs clean all zones. If you are not doing a nursing function or a scrub function and you're just in a room, you're expected to help. This is a teamwork kind of deal. We're all in this together. So you clean from high to low, bless you, and you clean the dirtiest items last. So you clean from clean to dirty. You mop the floor, in the cleanest to the dirtiest, and then you assess the room to make sure all items are clean and ready. So standardization of cleaning is what we're trying really hard to do. This doesn't start until the patient's left the OR. So don't expect somebody to be in there mopping the room when your patient's in the room. That's not going to happen. Vocalization of the zone taken. Proper use of cleaning cloths. We've looked really hard at the microfiber cleaning cloths that we use. That takes more than one cloth to clean a whole room. So this is not something you want to skimp on. And we're trying to assure that all steps are done. So again, if you're in there, I'm going to ask that everybody take a moment and look and see what's going on. And instead of standing in a doorway saying, hurry up, guess what? We can all help. So again, everybody can help turn a room over, RNs, surgical techs. Never hurry so much that you put the patient at risk. Clean the room completely prior to beginning the next patient in the room. No shortcuts. So I've been asked many questions about when the room is mopped and when someone can bring a new case cart for the next case. You cannot bring the case cart for the next case into the room until the OR has been mopped. That's just not a shortcut that we're going to take. So again, this is a teamwork situation. So I ask that we all treat each other with respect. And if you see something that isn't done, or you're just waiting, you should pitch in and help. Questions? Pam?
Where I came from, we had a regular wall cleaning. I have never seen that here.
No.
Apparently that's supposed to be done in terminal cleaning at night. Yeah.
So they're cleaning the walls at night every time they do the terminal cleaning?
Travis? Come up here, Travis, or let me get you this so we can hear your answer.
So Glenn Collins, myself, and Dan Rorish are going to start a once-a-month walkthrough of the ORs. We're still working on a day exactly, but we're going to start this in July. And yes, the walls will be checked thoroughly. That is something that needs to be done. I agree with you. It's not being done consistently.
Right.
So this is something we did bring up with environmental services, and we are going to be working together with them collaboratively to make sure this is done. So.
Thanks, Travis. Other questions? Chris?
Do you know if they're actually going to start wiping the top of the monitors to get all the dust and everything else? The
Yes.
booms?
Yes.
Since we're just pulling off like an inch of dust and perforating and everything else.
You're completely right. Dan and I did a walkthrough of the entire OR, made a note of where all the dust was, and there was quite a lot. We did bring the director and the manager of EDS in and did an inspection of the OR. And kind of showed them our findings, and they have agreed to work with us and address our concerns because there were several. I do agree with that. But this is something that we're going to be checking every month.
And I know there should be some periodic cleaning like the vents and the ceilings and things like that we're also looking into, that I sometimes wonder if that's been done. So, good questions. Any more questions? We're good? On we go. Correct wound classification documentation. This is for every nurse that works in the operating room. If you don't know what a wound classification is, you're in trouble. So let's just talk about what that means. Wound classification predicts the risk of post-op infection based on an assessment of the bacterial load at the time of surgery. So this gives you your risk that your patient has when they come in the OR to whether or not they'll become infected. So again, here they are, class 1 through 4. The cool thing is, you should be looking at this when you should be documenting at the start of the case. This can change during the case, and it's the RN's responsibility to make sure that once the case is over, they know what happened and they might have to change the wound classification. The cool thing is that in Epic, you can actually click on wound classification and it takes you to the screen. If you can't remember everything, and some cases are, kind of gray, you can go to this OpTime screen and it gives you this little algorithm that will help you determine your wound classification. Questions? Rose?
I honestly just wonder if this is something that should be included in the debrief and the surgeon.
It should be included in the debrief, Rose. You're right.
The surgeon should be calling it. If you move to a class as soon as you're talking itis,
I hear what you're saying, but this is not in their wheelhouse of documentation. This is our responsibility. We should be able to glean what wound classification that patient has by talking to the surgeon during the debrief. Like what was actually done, was there gross spillage, et cetera, et cetera.
But it seems as though getting from class 1 to class 2 is very ambiguous. And I've been told if it's not just cholelithiasis, but if you have inflammation of the gallbladder, no gross spillage, you move to a class 2.
So a
All gallbladders are class 2.
Yeah.
No matter what, they're class 2.
That's a minimum starting point because you're in that track.
GI tract.
Yeah.
GI tract.
So class 1 is very definitive, class 2 is very definitive, but class 1 never moves to a class 2. A class 1 can jump to a 3 or a 4 because you can only jump to contaminated or dirty depending on the circumstances. So there's usually a default setting for surgery where you would start, but you classify based on your patient presentation. So if your patient's coming in for an API, for example, the default setting for an API is usually a 2. Sorry. But if your API is red hot and huge, that is not a 2. That would be a 3. If your API is ruptured, you've now gone to a 4. So you classify your wound based on the patient presentation of that surgery, not the default setting. So in this wound class, they're making you work it backwards, which is actually a good thing. So your first question is there a wound? I'm kind of hoping there is if you're in surgery. And then they make you work down, which gets you, it makes it easier to get to the correct classification. It is not better to underclassify or overclassify. It is better to make it accurate. So when you come in, for example, with a gunshot wound, what would you start at? A 3. It's at least a 3, right? If we have perforated bowel, what is it? It's a 4. So it depends on what's going on in that case. So there really has to be some kind of conversation, or at least there has to be some hearing as to what's going on during that case for you to get an accurate patient classification. There's a lot of your cases, for example, total joints. If that total joint is a primary total joint is anything other than a 1, I question as to what we're doing. Why are we there? It should always be a 1. If, on the other hand, you're bringing a patient back for an IND, I shouldn't see a clean classification for that case. So that's the kind of thing that we're thinking of. And this is actually in your EPIC documentation record. So if you have a question, if you scroll down on this, it has classification. There's explanations for each category, and it gives you patient examples, which hopefully will help answer some of those questions. And if you have any other cases where there's questionable things about what should I do, please ask. Happy to answer that. Sometimes it's not easy to figure out, sometimes it is. But let me know if you have questions.
Oftentimes with gallbladder surgery, there's some leakage of the bile, so does that change it from a 2 to something else, or does it stay at 2?
Gross spillage bumps it up, but you're always going to get a little bit. If your gallbladder ruptures, that would bump it up. I think they define it on here. They give you actually a measurement. I think it's 5 mils, but I'm not sure. I have to look back and see what it is.
Okay.
So go ahead and look at this the next time you're in the intra-op record, see what you think, and see if it will actually help you.
Thanks, Kim. Oh, Kim, come back.
Okay, so prophylactic antibiotics. So we don't administer, the nurses don't administer the prophylactic antibiotics, but it is part of what we do as a team. So the prophylactic antibiotics are different per surgery, and it depends on your allergies, on your MRSA status, and what you're having done. So there is an algorithm for this. It's a lovely 3-page document. Do you have to know it all? No, you don't. You narrow it down, and you basically choose the documentation. The catch with this is it's not just about choosing the initial antibiotic, it's also knowing if you need to redose. So for any of you that have worked with Dr. Warden in the past, she was a fan of Moxetin 2 grams. The catch with that is it requires you to redose every 2 hours. And her surgeries would probably last 4+ hours. So again, it's not just about choosing the right antibiotic, it's making sure you know the redosing schedule. So we don't administer it, but as part of a team, we know the MRSA status, we know what they're having done, we can verify that we have an antibiotic, and we can also basically write maybe a redosing time on the timeout board or on the whiteboard so that we're all on the same page. Anesthesia will administer, but this is a great conversation point. Sometimes Vanco will be running, so if they are MRSA positive, they'll almost always get Vanco. Vancomycin for a lot of surgeries is not given as a single agent. So it's usually vancomycin plus. The other new thing is that Ancef and vancomycin are weight-based. So if you're over 120 kilos, you should have Ancef 3 grams. Your vancomycin can be given in 1 gram, 1.5 grams, or 2 grams, and it all depends on your weight, which is all on this algorithm. And this algorithm is on the OR website, so you don't have to look for it. So it's really important that we make sure that our patient gets the right dose and is redosed at the right time. Does anyone have questions about the antibiotics? Esther?
Just about patients that are on scheduled antibiotics.
Yeah.
I feel like most of the time the assumption is made that those patients are covered. Is that what you would say?
Not necessarily. So I'll take that back to infectious diseases, because what I've been finding sometimes is that even though they're on schedule, they will sometimes recommend that they get their pre-op antibiotics. But I will say in that case, it's usually evaluated on a patient-specific case, depending on what they're treating. So if they're basically dosed based on a particular disease process, they may be covered. That's usually done on a case-by-case basis. Any other questions? So please look it up if you have questions on how to read this or what your patient should get versus not get. It's a great conversation point. You know, do we have the antibiotic? Do we have the right one? Do we need to redose? Simple questions like that can ensure that we get the patient the right medication at the right time and the right redose. We are still practicing on some old protocols. This was actually just redone, and this is a mix of pharmacy, American College of Surgeon current guidelines, infectious diseases, infection prevention, pharmacy, and a bunch of other evidence-based protocols. So this wasn't just whipped up at a weekend event. So let me know if you have questions. I'm happy to answer them.
All right, I'm just going to say just a couple of words about the AORN perioperative nursing data set. This is a method that we have to document in our perioperative record a nursing care plan for our patients. We don't have to do what the floor does and go in 5 different screens. It's automatically embedded in our software. So the thing is that this improves our standardization by reinforcing nursing care plans routinely used in clinical apps. It improves patient care by improving data analysis, and it improves clinical research, and it provides a measurement of staff contributions, and it meets regulatory requirements. So why am I bringing this up? Because the 2 main goals in peri-op nursing are, everybody knows this, what are they, girls? Freedom of harm, we don't want to hurt our patient, and prevention of infection. So yes, there's a million things under these 2 things, but basically that's our job. Every day we come in, we don't want to hurt our patient, and we want to make sure we're doing everything in our power to make sure they do not leave with an infection. So again, our primary goal is our patient safety, and I think everybody knows that, and I'm just going to ask that we all try really hard to think about the basics. It may sound hokey, but if we do everything that we're supposed to do, hopefully our patient outcomes will be a lot better. So any questions? Pam?
Lately, when I've had a patient who has beard,
You have patients with beards?
beards, or patients who come into my OR filthy,
Yeah.
I either wash them totally, you know, the whole area that we're going to be working on in the OR, that's a big area in the heart room.
Right.
And I know the doctors are starting to recommend that the patients trim their beards, short, but it doesn't always happen. So there are contributing factors to these infections
Oh, yeah.
that really aren't our fault.
Correct.
That the patients are actually infecting themselves. And so I always document that also on the paperwork, because if you don't, there's no way to correlate the fact that this guy has a beard down to here and his chest wound is now infected 3 weeks down the road. Or if they're coming off the street, a lot of these people are living
Homeless,
on the street, they're homeless, and they're going back to that after they leave. And they have no cleanliness to deal with the issue.
That population is extremely difficult to care for. And, they are more apt to have an infection because of those very things that you're
Because
talking
of all the
about.
things that contribute to that, yeah.
It's worrisome to me that we're getting a patient that's that filthy.
Oh,
It seems that maybe pre-operatively they could be bathed or something.
Sometimes it's the patient's refusal.
Well,
They
there you
won't
go.
be touched. It's their curmudgeon or whatever you want to call them. They don't want
Well, and
anybody
that's-
messing with them.
And we're
And then when you
limited.
get them to sleep, it doesn't matter. I can do what I want
Right.
then. But, as far as cleaning,
I get it.
We'll forget she said that.
Jeffrey.
Is there any latest information on hair clipping, whether done in the OR or in pre-op?
Pre-op.
I'm gonna turn this over to Kim because
We're
we
still
finally got our little hair back thing.
Yeah, we're still clipping hair in the OR.
Yes, we are.
Yep.
For the GYN patients?
Everything.
We did urology yesterday and clipped the
So, clipping is kind of a hot issue. Yes, it's preferred to do it preoperatively. You can still do it intraoperatively if we have to, and we do have to in some instances, especially in a trauma or urgent case. Ideally, we do it preoperatively. The heart team just got a clip vac, which literally is like a little Hoover vacuum, basically to do hair control. Because they do most of the clipping in the OR, and part of their SSI prevention work was to get that in for them. So I can talk with you offline about doing that. And Rebecca, just to get back to you on the issue with the vendors, in order for the vendors to come in, they have to go through rep tracks and they have to jump through some hoops to get in here. So part of that is HIPAA, hand hygiene, and various things like that. So they don't just get to walk in to say, I want to be a rep here. But one of the things as part of our Back to Basics is we will send out a note to them to remind them of our traffic. And the reminder to that hand hygiene is a great thing to do. And then we can do it. And the first thing everybody's going to do when they go back to the OR today is what? Including, say that aloud? Including what?
I said clean our nails.
Yes.
With what? Thank you. My God, drink more coffee. Julia?
Are we gonna do any talk about the Sterilium application too, saying?
So Sterilium, we have Sterilium, everybody likes Sterilium. The key with Sterilium that I think people forget is it is not a 30-second application. You must, before the first application, wash your hands thoroughly and clean under your nails with a nail pick prior to the first application, and that is based on the manufacturer recommendations. You will hopefully this week see the manufacturer instructions for use posted at the scrub sinks as a friendly reminder of the use. And feel free to read those at any point in time. There's also a snazzy video that I could send out. I'll put it actually on the website so you can look at that at any point in time. Sterilium is about a 2-minute application because you start with your hands, go to your forearms. You should walk in the room rubbing your hands, not going like this. You should be rubbing your hands when you walk in. So just a friendly reminder on the correct application, it does not count to do it faster. You're not doing anything if you're not following the manufacturer recommendations for use, because the appropriate action of it is based on following the instructions. Miley?
I just wanted to talk, we have like some different hand hygiene products that are chosen, and then there's also just the hand pump soap. Now, when the CHG first came out on the market, which we have at some of our sinks and some are betadine, I was told that that's kind of your decolonization type of hand washing thing versus like the hand soap thing. So I didn't know if that was being looked at as far as like what's the best product to use for our morning hand wash.
You can wash with any product that you like, as long as you're washing with soap and water. You can use CHG. The CHG is also there because we have scrub brushes that don't have any product on it, so some people like to do a scrub with CHG. So that's your option, because the other two brushes are impregnated with various products. So CHG in the bottle is there as an option, because we don't have those brushes that are impregnated with CHG. Any other? Sarah?
I just wanted to circle back to the question about when you do soap and water.
Sarah, come up here and use the microphone, please, ma'am.
Just remember, if you have somebody on enteric precautions, you must use soap and water. The alcohol-based products are not effective. Soap and water is your friend. And then you must do a bleach wipe down after that.
I was just going to clarify the question earlier that was asked about soap and water versus the Purell. So the reason that you want to use soap and water is anytime you go to the bathroom, anytime you eat, or anytime your hands are visibly soiled, or as Kim just mentioned, if you have an enteric contact precaution patient, all other times you can use Purell. But basically just think about it, if your hands are dirty, the Purell isn't going to be able to get through to actually disinfect your hands. So hopefully that clarifies. Yeah.
Should you also wash your hands in between caring for different patients, like Becky has in her case with 44?
You need to perform hand hygiene, but you have the choice of whether you want to use soap and water or Purell. Purell, when your hands are not visibly soiled, is actually the preferred method because it kills the organisms on your hands. Versus soap and water, you have to have that friction and rinsing to be able to get your hands clean.
And what about when someone breaks scrub, would it just be the Purell then? Or?
Yeah, as long as they don't have visible soilage, they can just use Purell. Yeah, good questions. Anything else?
Any more questions? Yes, Andrea.
Clarification, I have a two-part question.
Part A, hit us.
One,
Part A.
are we still following the new practice of scrubs and totals don't get scrubbed out until the dressing is on? And if that's the case, would that also assume that once you scrub in a total, you scrub in wearing a hood and don't scrub out until you're done? That's my question.
So there's a lot of things happening with orthopedics right now. We've been trying a lot of different things. The latest version was that we did not break until the dressing was on, and we're still sticking with that, Renee? Did we change that back?
Hopefully only for like another week.
So we were giving that a trial because we needed to look at that. So yes, for right now it is. We do have another meeting for an update on orthopedics. What's that?
I think it's next week.
Next week? Okay, this week or next week we're meeting to basically check in to see that. So yes, for right now, we're not breaking until the dressings are on in totals.
It's the 14th.
14.
So then that means that you set up with a hood and a helmet and then don't scrub out, right? Because it would be the same thing. Why would you scrub out in the middle, the beginning of the case? That's my question.
That was not determined.
I'm asking, because I see a lot of that, people will scrub in with just a mask and set up a whole toner joint and then scrub out and then scrub in again to do the case.
So the whole point of not breaking out was because the joint was open, and the determination was we wanted the wound essentially covered before you break out. So we didn't discuss the pre-op phase of that, so no, we didn't cover that piece of it. It was all about essentially the wound being open and then the wound being covered prior to the breakout. But ultimately, the bottom line with all of the rooms is traffic. So use your phones before you go in. The biggest thing that I saw, I know when I was in cardiac, and the only reason why I'm pointing out cardiac is because I got to spend 3 days with cardiac, was holding the door open to have a conversation. So try not to do that. Or I should just say, don't do that. Because that basically changes your entire airflow in the room, and we rely on our airflow to basically keep the contaminants away from the field. We disrupt the airflow every time we open the door, and if we hold the door open, then we basically completely disrupt the airflow. Any other questions for Julia?
Are we getting cards for the total joint implants so that they don't have to open the door 4 times a case?
I believe they had carts for the implants, so they could shop ahead of time.
Nope.
Julie's saying no.
Well, they do. I don't know where they are, but yes, they do. And we spoke to vendors about that. And we even moved the implants closer so that would allow them easier access. So we're trying to make it where it's not onerous on the vendors so that they have what they need. So if they're not using the carts to bring things in, that would be something that
They're
Renee.
bringing smaller carts into the core, but they're not bringing any implant carts into the room, as far as I've seen.
Let me check with Mike.
I've never seen it.
So ideally, the process was that the bulk of the implant carts were brought down to the second floor from the third floor. They were given carts, smaller carts that could be basically loaded with implants for case that they could bring into the room. That was the idea of it. Obviously, that's not happening. So Tony's gonna check back with Mike to see what that process was, because they did have carts made available to them for that purpose, so they would reduce those trips.
Times when, on a meeting where you just open implants one time, but
Right.
there's, you bring, they have to go get 4 separate things each time, and so it's.
Yeah. So they were given carts to basically reduce that, because they should be able to at least have a selection of implants that they should be able to pull from in the room for that case.
Well, they have carts, they just don't have enclosed carts.
I've seen one, and it's been.
There were 4 and 3 more ordered, so I'll ask where they are.
Yeah, I've seen one.
Okay. We'll check back on that.
Now they just take our open case carts for cases and then try to take that.
We'll check back on it, because they're supposed to have their own designated carts for that purpose specifically, to reduce that. Yes, ma'am.
Where do you want these papers?
Why don't you just leave them at the front, I'll take them up. If you didn't get one, there'll be some at the control desk.
Anything else? It? All right. Have a good day, everybody.